Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Elford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past and present. I'd also like to acknowledge Telematics and thank them for providing us with the funding to deliver this webinar. The focus of this webinar will be on genetics and ovarian cancer. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour you can ask questions to the presenters by clicking on the blue hand icon at the top of your screen. Questions will be answered by each speaker at the end of their presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. This webinar is being recorded and will be posted on the Ovarian Cancer Australia website. If you're having trouble with the sound, you can dial the 1800 number listed in the chat box. So I'm extremely privileged to introduce our presenters to you. Our first presenter is Ms. Megan Cotter, who is a certified genetic counsellor with over 7 years of experience, clinical experience. She has a special interest in familial cancer and neurogenetics and is currently working on a project with Ovarian Cancer Australia to increase the rates of genetic testing amongst women with a diagnosis of ovarian cancer. She'll provide an overview of genetics and ovarian cancer and talk about the process of genetic testing and how eligibility for genetic testing is assessed. Our second presenter is Associate Professor Marion Harris. Associate Professor Harris is a medical oncologist, clinical geneticist, and Director of the Familial Cancer Centre at Monash Health in Melbourne. In medical oncology, she works in the breast and gastrointestinal tumour streams. Her clinical research studies particularly focus on familial, breast, gastrointestinal and pancreatic cancers. Associate Professor Harris will discuss the medical aspects of genetics and ovarian cancer and the potential outcomes and implications of genetic testing. And our final speaker is Ms. Christine Christie, who sought genetic testing after discovering that her father carried the Brca1 gene. She also has the Brca1 gene and discovered that she had ovarian cancer after having preventative surgery. She will talk about her experience and why genetic testing has been so important for her. So I'd like to now bring to the microphone our first speaker, Ms. Megan Cotter. Thanks, Megan.
Thanks, Vanessa. Okay, so as Vanessa mentioned, my name is Megan Cotter and I'm a genetic counsellor. And part of my role as a genetic counsellor is to meet with people with a personal or family history of cancer, to clarify if there's a strong genetic link to the cancers in the family. And this process involves gathering family history information, assessing if genetic testing is appropriate, facilitating genetic testing when appropriate, and then providing risk information to that person and their family members. And so today I'm going to focus more on genetics and ovarian cancer, and pull my slides up. And so as an overview of my talk, I'm going to provide an overview of genetics. I'm going to talk about inherited versus sporadic cancer and how we look at those things. I'm going to talk about genetics and ovarian cancer briefly, but my colleague Marion will discuss that in greater detail. And then I'm going to talk about the logistics side of things, so what genetic testing actually is, what it involves, and what genetic test results actually mean. And we also know that people have concerns about genetic testing, and two of the main concerns we receive feedback about are cost and insurance aspects of genetic testing. So I'll touch on those as well. So when talking about genetic testing, we're talking about examining the genetic material which is found in every cell of our bodies. This genetic material is called DNA, and DNA contains coding regions and non-coding regions. And the coding regions are called genes. And DNA is packaged into structures called chromosomes, and each cell of our body contains 46 chromosomes. And chromosomes come in pairs. So we have 23 pairs of chromosomes. And we inherit one copy from our mother and one copy from our father. So this means that we inherit 50% of our genetic material from our mother and 50% of our genetic material from our father. So genes are essentially recipes that make proteins, and proteins have various functions throughout our body that make it work as it should. When there's a spelling mistake in the recipe, or also known as a genetic fault or a mutation, this may cause an abnormal protein to be produced or no protein at all. And so this is what we're looking for when we do genetic testing, to see if there is a spelling mistake in the gene which stops it from working properly and producing an incorrect protein. And we know that some genes are responsible for cell growth, and when genetic faults accumulate in these genes, cancer may develop. So when we look at cancer, we look at it as whether it's inherited or sporadic. And it's important to be aware that all cancer, it can be seen as genetic, but it's also important to be aware that cancer doesn't develop just because of one fault in one gene. And so we know that cancer develops because of an accumulation of faults in multiple genes over time, which lead to uncontrolled cell growth. Now, this staircase diagram that you can see on the slide is a way to represent this. And it shows that each step represents the progression of genetic changes that develop in different cancer protection genes. And it shows the progression of a normal cell to becoming a cancerous cell. And so when people inherit a faulty gene in one of these cancer protection genes, it means that they start off on one of the higher steps. So it means they have an increased risk of developing cancer compared to someone in the general population. So that's just a brief overview of genetics and how we look at cancer and genetics. Now, thinking about ovarian cancer and genetics, we need to think about the subtypes of ovarian cancer. And we know that the majority of ovarian cancer, so about 90%, can be described as what's called epithelial ovarian cancer. And this means that it arises from the cells covering the ovary. And fallopian tube cancer and primary peritoneal cancer can also be classed under this epithelial ovarian cancer umbrella. There are other types of ovarian cancer, such as germ cell tumours and stromal cell tumours, but for the purpose of this talk, I'm going to focus on epithelial ovarian cancer because we know that approximately 20% of women who have epithelial ovarian cancer have a genetic fault in one of these genes that increase the risk of developing ovarian cancer, so it's classed as hereditary. So the graph that you can see on this slide represents the genetic faults identified in women with epithelial ovarian cancer. So lots of studies have looked at the different types of genes that are in women with epithelial ovarian cancer. And in this study, we can see that the majority, so about 80% of these genetic faults identified in women with epithelial ovarian cancer are found in the Brca1 and Brca2 genes. Now, faults in these genes are associated predominantly with an increased risk of developing breast and ovarian cancer. We can also see that a small proportion of genetic faults are identified in what's called the Mmr genes, and these are the genes that are associated with Lynch Syndrome. And Lynch Syndrome predominantly increases the risk of developing bowel, uterine and ovarian cancer, but it can also increase risk of developing other types of cancer. And there are also a significant number of faults identified in other genes. And separately, these genes don't account for a large proportion of hereditary ovarian cancer, but together they contribute a significant amount. But given they are less common, less is known about the specific risks associated with these genes, and they may not be tested for in a clinical setting. And I think Marion's going to go into a bit more detail about each of these types of genes and what they mean with respect to ovarian cancer. Now, the majority of the genes that are associated with ovarian cancer are inherited in what is called an autosomal dominant pattern of inheritance. So, as I mentioned earlier, we have two copies of every gene, one inherited from our mother and one inherited from our father. And when a gene is said to be inherited in a dominant pattern, this means you only need to inherit one faulty copy of the gene in order to be at risk of developing that condition. But most of these genes that increase the risk of developing ovarian cancer show variable penetrance and also variable expressivity. So what this means is that you may have an increased risk of developing cancer, but not everyone who inherits these genes develops cancer. And the type of cancer that may develop can also vary from person to person, even in the same family. So this family tree on the slide is a typical family tree of a family who has a BRCA1 genetic fault. And it's showing 3 generations. And what it shows is that the circles represent women and the squares represent men. And the black circles are those women who have had a diagnosis of ovarian cancer. So for example, the woman at the top had a diagnosis of ovarian cancer at the age of 49. And then the people who have inherited the BRCA1 genetic fault are shown by the positive sign next to the symbol. So as you can see, the type of cancer that develops and the age that it develops varies between family members. So we've got 2 women diagnosed with ovarian cancer at 49 and 53, and then also 2 women diagnosed with breast cancer at 42 and 38. And this also shows that the 2 women diagnosed with breast cancer at the bottom have inherited it from their mother and father who have not inherited, who have not developed cancer, but they do carry the gene. So sometimes it can look like a gene is skipping a generation, but this is not the case. It just demonstrates that a person can carry the genetic fault and not develop the cancer. And it's also important to be aware that men can carry these genes, but the cancer risks associated for men are much lower than they are for women. So what actually is genetic testing? So genetic testing involves the analysis of an individual's genetic material. And in a family cancer clinic, there are 2 main types of genetic testing that we think of when it comes to these cancer genes. And the first type of testing is called mutation detection or mutation searching. And this is essentially the process of looking for a spelling mistake in one of these cancer genes, which would explain the diagnosis of cancer in the family. And sometimes this can be likened to the process of trying to find a spelling mistake in an encyclopedia. So genes are made up of lots and lots of different letters, and that's when we're trying to find a spelling mistake in those letters, which has stopped the gene from working properly or not. This type of testing is most informative if it starts in someone who has had ovarian cancer or who's been affected by cancer. And then if a spelling mistake or a genetic fault is identified, then testing is much simpler in other relatives, as we know exactly what we're testing for, because each family has their own specific genetic fault. If testing is done for a specific genetic fault that's been identified in the family and that person has not had cancer themselves, that's what we call predictive genetic testing. And that's because we're testing someone and we're predicting what their risk of developing cancer is based on that genetic test result. So from a logistics side of things, genetic testing is usually done on a blood test. Sometimes it's done on other samples, but most of the time it's done on a blood test. And it's usually arranged through a family cancer clinic. So you would usually be referred to a family cancer clinic and they would go through a consenting process and would facilitate that testing for you. However, some oncologists and surgeons have started to order genetic testing themselves to assist in treatment planning. Results can usually take up to 2 months, but sometimes they can come back quicker, and it can vary depending on the test ordered and the actual lab used. So what type of test will you be offered? So the type of genetic testing you would be offered depends on a number of things, including the age at diagnosis, your family history, and the pathology of cancers. But it may include one of the genes that I was talking about earlier, so say BRCA1 or 2, the Lynch syndromes, or some of these rare cancer genes. And testing has evolved rapidly, and we are now able to test lots of genes at the same time. So sometimes you might be offered a panel of genes, so testing for multiple of these genes at the same time. So should you have genetic testing? It's really important to be aware that you are not obligated to undergo genetic testing. It's completely voluntary, and the decision needs to be made taking into consideration all of your personal and family factors. And that's, I guess, what the conversation through the consenting process is about. It's about deciding whether this is the right time for you to have a genetic test. Some benefits around genetic testing, particularly in the area of ovarian cancer, include that it might inform current treatment options, it could inform future cancer risks, and it also provides information for unaffected relatives. We do know, however, that some people have concerns about genetic testing, and a survey conducted by Ovarian Cancer Australia revealed that some of the main concerns people have were around the timing of testing. So some people felt that it was just too much while they were undergoing treatment. And also some people are worried about the implications for other family members. And also two of the main concerns were people were concerned about the impact of insurance and also the cost of testing. So I'll touch on these. But it's important to be aware that if you do have concerns about testing and you're not quite sure if you want to go ahead, you may benefit from speaking to a genetic counsellor, as they'll be able to talk through those issues with you. So what does a genetic test reveal? So there are three possible outcomes with genetic testing. And that's the genetic testing I was talking about, where we're trying to find a genetic fault in a family. So the first outcome is a genetic fault or a mutation is identified, and this is what is called a positive result. So this means that a cause for the cancer in the family will have been identified. It also means that you may be at risk of developing other types of cancer, and it also means that your close relatives are able to have a test to clarify their risks of developing cancer. The second outcome, and this is the most common outcome with genetic testing, is that no genetic fault is identified. And this is what's called a negative result. This is because no cause for the diagnosis of cancer has been identified. And sometimes this type of result is called uninformative, as it is possible there may be another gene or other genetic factors that are influencing cancer risk in your family that we're currently unable to test for. And in this circumstance, we're unable to offer testing to other family members to clarify their risk of developing cancer, and we would use the family history as a way of assessing other family members' risks of developing cancer. And the third outcome with genetic testing is that we find a variant of uncertain significance. And this is still classed as a negative or an uninformative result. But what it means is that a spelling mistake has been identified in a gene, and it's not quite clear whether it stopped the gene from working properly or not. In this circumstance, we wouldn't offer testing to other family members to help clarify their risk of developing cancer, because we wouldn't want people to make decisions based on uncertain information. But it's important that if you do get a result, a variant of uncertain significant result through your genetic testing, it's important to keep in touch with your familial cancer clinic every few years, because our knowledge around these variants changes over time, and they would be able to update you on the current knowledge around the variant. Now, one of the most commonly asked questions is, how much does genetic testing cost? And as a general rule in Australia, women who have a greater than 10% chance of identifying a mutation or a genetic fault are eligible for a Medicare-funded genetic test. Now, some women automatically qualify for genetic testing based on their age and the pathology of their cancer, but some women will need to undergo an assessment to determine if they are eligible. And things that are taken into consideration are the age that people are diagnosed, the pathology, the ancestry, family history, and also family structure. Now, if you're assessed to have a less than 10% chance of identifying a genetic fault, there is the option of self-funding genetic testing. And this costs approximately $500, but prices can vary depending on what lab is used. And when I'm talking about this type of genetic testing, this is the testing that I was talking about with mutation searching or mutation detection. So it's important to be aware that if there is already a genetic fault identified in your family, then testing should be funded by your local family cancer clinic. Now, one of the other main concerns people have is about insurance. And these are some significant questions that we get asked. So it's important to be aware that health insurance cannot be impacted by genetic test results. They cannot change your level of cover or your premium based on your genetic test results. But genetic testing may impact the cost or terms of life and income protection insurance. So when applying for life or income protection insurance, you're not required to have a genetic test, but they may use a genetic test result in the assessment. There is a proposed moratorium or a ban on the use of genetic test results, and this is supposed to take effect in July 2019 until at least June 2024, but it's not guaranteed that this will take effect, and it is only up to a certain level of cover. So if you have specific concerns about insurance, we recommend that you contact your local financial advisor for more specific advice. But the key thing is that it can't impact health insurance. So where can you get more information? So these are some really good websites, and we'll put links on these to these websites on the Ovarian Cancer Australia website, and these are where you can get further information about genetics and ovarian cancer. But if you do have specific questions about genetic testing, I recommend you go to your doctor and ask for a referral to your local family cancer clinic. Thanks. So I think over to you, Vanessa. I think we'll open it up for some questions.
Sorry, yeah, thanks very much, Megan, for that extremely informative presentation. We do have a couple of questions that the audience has posted. Sure. One is, I think my sister had genetic testing before she passed away, but I'm not sure. How do I find out?
Sure. So it's really important that you get a referral from your GP to a local family cancer clinic, and they'll be able to look into this for you. So what they'll do is they'll probably gather some information about your family history just to update to see if there's been any further diagnoses since your sister passed away. And they'll also be able to contact the family cancer clinic where your sister was seen to get that information. And so if there's consent to release that genetic test result, they'll be able to access that, and they'll be able to, I guess, show what was tested for and what that means for your level of risk.
Great, thank you. And one more question. I have ovarian cancer, but haven't had testing yet. I don't live in a capital city, so am I able to still access genetic testing?
Yes, of course. So it would be important, once again, to get a referral to your local cancer clinic. And it's important to be aware that cancer clinics are all over Australia. So they're in every state, and they also provide outreach clinics and can conduct telehealth clinics. So there's a way of making it more accessible if you aren't able to go into a capital city. So,
fantastic. Great. Thank you so much again, Megan, for joining this webinar. We really appreciate your time. I'd now like to hand over to our next speaker, Associate Professor Marion Harris. Thanks, Marion.
Good afternoon, everyone. I'll just kick straight into my slides. There's going to be a little bit of repetition, but not too much. So as Megan touched on, there are different cells in the ovary that can become malignant, and we focus on the epithelial ovarian cancer that makes up the majority. There is a subgroup of these type of cancers that include borderline ovarian tumours, and these have low but not zero malignant potential, meaning ability to invade and spread. And we'll talk about later that while epithelial ovarian cancer is associated with a higher risk of hereditary predisposition, the borderline ovarian tumours are less associated, particularly with BRCA1 or 2 gene changes. As Megan said, different type of ovarian cancer is a cancer that arises in the germ cell. They're the egg cells of the ovaries. And then similarly, the sex cord tumours of the ovary, basically the connective tissue of the ovary that give rise to different types of tumours. And these latter two, the germ cell and the sex cord tumours of the ovary, are less associated with hereditary predispositions. Also, as Megan touched on, within the epithelial ovarian cancer groups, there are some different types of histologies, or the appearance that the pathologist can see under the microscope. And the most common is referred to as the high-grade serous, and that's the cells have a certain appearance under the microscope, and that's the commonest type. And then there's the mucinous ovarian cancer, where the goblet, the mucin droplets can be seen in the cells. Then there are clear cells, which also have a different appearance to the pathologist's eye, and then also the endometrioid. So they're the commonest types of epithelial ovarian cancer. And sometimes they can be mixed, so a combined endometrioid and clear cell, or serous with a touch of clear cell. So with genetic testing, we often talk in clinic about germline genetic testing, and that's when we're trying to test the cells, usually from the blood, but they can be from the skin. These genetic changes are thought to be representative of the genetic makeup of all the cells in the body, and that therefore includes the egg cells and the sperm in the gonads that could be transmitted on to the next generation. And just to draw a difference, increasingly in this day and age, people are having tumour cell testing, which is often called somatic genetic testing, whereby the tumour testing is tested. So it's just important to draw that difference. And so mainly when we're talking about genetic testing in familial cancer clinics, we're talking about germline genetic testing, whereas in oncology clinics, we're often more focused about tumour testing, perhaps particularly with some other, tumour types like lung or colorectal. So a mutation, as we've heard, is an alteration or change in the DNA. So when we do genetic testing, we're trying to see if we can identify any disease-causing mutations that would produce an altered protein or lack of protein. And as we've heard, increasingly as more and more genetic testing is undertaken, we sometimes increasingly find a gene change of uncertain significance when we're not sure if it affects the protein and therefore whether it affects the health of the person or the gene product that's made. So increasingly, we have to look at ways of how that's going to be sorted out. So I'm going to go through these conditions one at a time. So I just wanted to list them. So up the top, BRCA, breast ovary cancer syndrome, was the main focus of our attention in ovarian cancer until the last few years. Lynch syndrome, we've heard, is associated with colorectal and uterine cancer and sometimes ovarian cancer. We'll touch on some Mmr genes that have really only been in this space and certainly in the genetic testing space in the last few years, RAD51C and D, and then some other mutations. So I'll go through them one at a time. So breast cancer gene 1 and breast cancer gene 2, sometimes called Brca1 and Brca2, they're DNA damage repair genes. So the cells in our bodies are replicating their DNA often. And when in that process where 30,000 genes are being copied, errors can be made. So having a repair mechanism to correct that's very important. So if this is faulty, this can be an important cause of genetic alterations. As you've heard, in these conditions, move in steps. When you have a hereditary predisposition, one copy of, say, your BRCA1 is already altered. You start from a higher point up that staircase. With BRCA1 and 2 gene changes, we generally say in our community, we think about 1 in 400 people might carry this gene change. We know that in the Ashkenazi Jewish population, the chances of any random person carrying a BRCA1 or 2 gene change is much higher, about 2.5% or 1 in 40. And there are so-called founder or commonly found changes in people of certain ethnicities. So in particular, there might be Indian founder mutations or Dutch founder mutations, and also Iceland. Not that we see many Icelandic people here in Australia, but it's a big thing in Iceland. So those who carry a BRCA1 or 2 gene change, if they're female, are said to have up to a 7 in 10 or 70% lifetime risk of developing breast cancer and up to a 50% lifetime risk of developing epithelial ovarian cancer that's most commonly high-grade serous cancer. And the average age of diagnosis is approximately in the 50s. With a BRCA2 gene change, once again, the lifetime risk of breast cancer in a recent series was the same as BRCA1, so 70%, but the ovarian cancer risk is lower, around a 10 to 20% lifetime risk. But the average age of diagnosis is a bit older, in the later 50s. As I mentioned, most the tumours associated with these are high-grade serous, but also can be endometrioid or clear cell cancer. And typically, BRCA mutations are not found in the lower-grade serous adenocarcinoma of the ovary or the so-called borderline ovarian tumour that are more usually confined to the ovary and have a lower risk of becoming invasive and spreading outside the ovary. And also in the mucinous adenocarcinoma of the ovary, BRCA mutations are seldom found. And so those subtypes of ovarian cancer would not routinely be offered BRCA1 or 2 gene changes because of that reason. So what are some of the indicators that we look at when we're wondering, could someone with ovarian cancer have a BRCA mutation? So we'd always look, does that person now with ovarian cancer have a personal history of breast cancer, or is there a family history of either breast or ovarian cancer? Looking at the close relatives, the first or second degree relatives. And the breast cancer we might see in BRCA families is classically a high-grade triple-negative breast cancer, or one that occurs at a younger age, or someone might have had bilateral, both-sided breast cancer. With the family history, as we said, we're looking for any types of epithelial ovarian cancer, especially serous. We're looking to know that person's ethnicity, so any particularly Jewish ancestry. In men, BRCA gene changes associated with an increased risk of prostate cancer, especially BRCA2, and that's classically high grade, so we're also interested in that. Individuals with BRCA2 gene changes do have some increased lifetime risk of developing pancreatic cancer, around the order of 5%, so always looking in a family tree, is there any personal or family history of that? With respect to age at diagnosis of ovarian cancer, the literature shows us that the chances of finding a BRCA gene change are rarer in certain age groups, and that includes the very young. So as soon as you see someone who's had epithelial ovarian cancer diagnosed under 30, we know the chances of finding a gene change are lower than if they were diagnosed, say, in the 50s or 60s. And similarly, as you get to an older age group, over 70s, the chances of any one person with epithelial ovarian cancer having a BRCA mutation are lower. So generally, and particularly because ovarian cancer types can be mixed and sometimes can be hard for pathologists to accurately tell, is there any serous component to that clear cell or endometrioid tumour, all invasive epithelial adenocarcinomas of the ovary that are not mucinous and not borderline are generally offered BRCA genetic testing. And sometimes some groups apply an age limit, so only do under 70, but I think increasingly with gene panels testing being cheaper, the idea is just to spread the net. So when we offer a woman with ovarian cancer genetic testing, we're doing it because we're interested in optimising any therapy options for the treatment of that ovarian cancer. And in particular, it's recognised that if someone carries a germline BRCA mutation, their disease can be especially responsive to so-called PARP inhibitors. So these are a type of therapy. PARP is just an enzyme. I've given you the name there, poly-ADP ribopolymerase. It's an enzyme involved in DNA repair. So in individuals with a BRCA mutation, double-strand DNA repair is defective in the tumour. So if then this targeted therapy inhibits single-strand DNA repair, this is a lethal hit to cancer cells, and yet normal body tissues still have that functioning BRCA, one copy of the BRCA that's functioning well, so they tend to be relatively resistant. And the good thing about PARP inhibitors is that they're oral, they have lower toxicity than standard chemotherapy, and so currently these drugs are PBS, so reimbursed by our system in the maintenance therapy for those who've had relapsed ovarian cancer, who re-respond to platinum chemotherapy and who have a germline BRCA mutation, and they're indicated in that maintenance phase to increase the time until there's any evidence of further disease activity. And the PARP inhibitor mainly used in Australia is called olaparib. Olaparib, the PARP inhibitor, can also be used as a single agent down the track in third or more line therapies. And typically we know that if someone does carry a BRCA mutation, they're often very treatment responsive and respond very well, sometimes to multiple lines of retreatment with platinum therapy that can in some cases go on for a number of years. So it tends to be viewed as a favourable prognostic factor, and that they may be, but not always, be long-term responders to treatment. Of course, if the individual with ovarian cancer does have a BRCA mutation, there is some increased risk of breast cancer, and depending on how their ovarian cancer treatment's going, that may or may not be so relevant. When we offer a woman with ovarian cancer genetic testing, we're also focused on her family members. So there's then, if a gene change has been identified that's disease-causing, then predictive genetic testing can be offered to unaffected relatives, whether they're male or female. And for affected female carriers, there's the option of having surgery to remove the ovaries and tubes. That's called bilateral, both-sided salpingo ovarectomy, removal of the tubes and ovaries. And this is recommended for female BRCA1 carriers by 40 and by 45 in BRCA2 carriers. And that's just because the age at which the ovarian cancer risk increases is different in the two genes. Usually there's no need to remove the uterus, but that is sometimes undertaken for different reasons. And there's always a small risk of a so-called primary peritoneal cancer. You know, the cells that occur in the ovary line the peritoneum, and so can't always be completely removed. And these women also have a breast cancer risk, so they can look at MRI surveillance, preventive mastectomies or use of tamoxifen. And for men, it's the ability to pass the gene change onto their daughters, but also particularly with BRCA2, an increased risk of prostate cancer, and screening options are available for that. So I'm just going to move on through this, but depending, different chances of there being a BRCA mutation. And generally this varies from sort of 13% up to about 20%. So I've just listed some figures here from one series, so suggesting that around at least 13% of all epithelial ovarian cancers carry a BRCA mutation. They're saying 15% for primary peritoneal, a little bit higher for the fallopian tube cancer at 20%. High-grade serous, a higher rate, so dropping down with the clear cell, less likely, especially if it is really a pure clear cell adenocarcinoma of the ovary, a lower chance of finding mutation, but there may be a mixed serous component. Endometrioid cancer, a little bit higher. So we're interested in high-grade epithelial ovarian cancer, there'll be a high mutation rate. As soon as it becomes low-grade, the chance for mutation are much less. Just jumping back to Lynch syndrome, which is usually a hereditary colorectal and endometrial syndrome, where ovarian cancer, I've listed some figures for you there. The risk for there are 5 genes that commonly cause Lynch syndrome. So for MLH, 1 gene carries the lifetime risk of ovarian cancer with their females around 10%. So by contrast, the colorectal cancer risk is much higher, and so is the uterine cancer risk. So ovarian cancer is less of a feature in this condition, but still can be a part of it. And the type of ovarian cancer people with Lynch syndrome get are a bit different. They're more of the mucinous endometrioid clear cell and less of the serous type. And another feature of Lynch-associated ovarian cancer is it usually occurs before the age of 50. So in Victoria, when most women with epithelial ovarian cancer access BRCA testing, we would always routinely test mismatch repair genes in most centres in Victoria undertaken where that ovarian cancer was diagnosed. The current cutoff we use is less than 60. For other tumours like a borderline ovarian tumour, it's not routine that they would always be screened for Lynch syndrome, but I think the family history would always be taken and it would be considered, particularly if someone with a borderline tumour or a primary mucinous adenocarcinoma had a sibling, say, that had colorectal cancer. So I think that's more take the family history rather than being absolutely routine. So there are management options if someone has Lynch syndrome and has epithelial ovarian cancer. These tumours, by nature of their exact type of genetic alteration, are called microsatellite unstable. That just means there's so many DNA repair errors, there's a lot of genetic variation, and these tumours often respond to immunotherapy. And so this is a therapy option that you'd consider if you knew that someone had a Lynch syndrome-associated epithelial ovarian cancer. Immunotherapies are generally being explored for all women with epithelial ovarian cancer, but it's a special consideration if we knew that someone has Lynch syndrome. And of course, for the individual and their family members who, if they have Lynch syndrome, there's the option of predictive testing and then offering colorectal cancer screening to family members, as well as thinking about the individual in front of you. Of course, the management of their ovarian cancer would take precedence, and so doing colonoscopy may not be appropriate. I've jumped ahead. So the issue about whether family members, the colonoscopy, and if they're female, increasingly some women who carry a Lynch syndrome mutation elect to have, usually in their mid-40s, to have a preventive hysterectomy and salpingo-oophorectomy, removal of ovaries and tubes, to reduce the risk of both endometrial and ovarian cancer. And just to contrast that with the BRCA carriers, in whom the uterus is usually but not always left. So just jumping on, increasingly in the last years, other hereditary predispositions to ovarian cancer are being considered more routinely in clinic. Now, particularly, I just mentioned before these genes called RAD51C and D, and another gene called BRIP. These are inherited in the same way as BRCA1 and 2 gene changes. They're also involved in DNA repair. The lifetime risk of ovarian cancer is said to be in the order of 5 to 10%, so more along the lines of BRCA2 than the higher risk, 50% lifetime risk with BRCA1. The breast cancer risk is yet to be established, some studies suggesting the breast cancer risk is increased and others being less certain, thinking they're more ovarian risk genes. So people who carry these gene changes, particularly for their relatives who might be found to carry the gene change after, say, their sister's been diagnosed, these people are suggested to consider having preventive bilateral salpingo-oophorectomy, removal of the ovaries and tubes, at around age 45 to 50. So the age of onset of ovarian cancer in these conditions is thought to be later than occurs in the BRCA1 and 2. And because these are new, we are learning more about them all the time. I just want to mention some other genes so increasingly now we have these gene panels. They're cheaper. We can test for multiple genes at a fraction of the cost that it used to cost to test for just BRCA1 on their own. Other genes that in series of women with ovarian cancer have been found include these genes called CHEK2 and ATN. These are different genes that are thought to have some increased moderate risk breast cancer genes, but they are found in some studies to be quite prevalent in people who have had ovarian cancer. So I think there's a lot that's still being worked out and determined, and there's a lot of things that are unclear. So I think this is a very active area and more studies over time. Just going to mention, I've listed there a few other genes that are mentioned, PALB2, BARD, things that are really still being associated but possibly carry some increased risk of ovarian cancer. I was just going to have a summary slide. So all non-mucinous, non-borderline ovarian cancers diagnosed, I'd say, at any age, but especially under 70, should have BRCA1 and 2 genetic testing. With the cancer gene panels, most ovarian cancer diagnoses diagnosed under 60 really should also be tested for the Lynch syndrome, which was the mismatch repair genetic testing as well. I'd say the chances of, if we don't find a BRCA1 or 2 or a Lynch syndrome gene change, the chances of these other RAD51C and D is much less likely, but I suppose that in an ideal world, you would test for them all so that you could say you've had BRCA1 and 2, you've had mismatch repair, you've had BRIP, RAD51C and D. Truly, that's as most as we can currently test, and if we've excluded all of those to the best of our ability, we're into the sort of research box about it's either not hereditary, it's either occurred as a one-off, or is it something yet to be determined or worked out. So just to clarify, the borderline or low-grade epithelial ovarian cancer, clear cell endometrioid, primary mucinous, consider Lynch syndrome, and screening for Lynch syndrome can either be done by genetic testing or an immunohistochemistry test on the tumour tissue looking for a missing protein. I did just want to mention there are some other rare hereditary conditions associated with other types of ovarian cancer, but I only just want to mention them in passing because they're really very rare. So in a hereditary bowel condition called Lynch Syndrome, it's a bowel polyposis syndrome, ovarian stromal tumours, so tumours of the connective tissue of the ovary, can be associated. And there is a rare type of a small cell that's a neuroendocrine type carcinoma of the ovary where there's an elevated calcium. There's also an underlying hereditary predisposition. I was going to just finish by showing a recent case series that was published a year ago, and they were about 4,500 women with epithelial ovarian cancer had multi-gene panel germline testing of 32 genes. Now, in this series, overall 13% had a mutation, a disease-causing gene change detected. So that was a bit lower than expected. It could have come up as high as 20%, so it's going to vary according to the types of ovarian cancer in the group. 25% had a variant of uncertain significance, and generally when that happens, ideally those variants are followed, and hopefully the idea is that over time those variants will be reclassified, and many of them will perhaps be found not to be significant, but a small number of them might turn out to be disease-causing gene changes. So out of the group, 52% had a so-called negative or uninformative test. In this group, the median age of the cancer was around 59, 60, which is typical. About 20% had a family history of ovarian cancer, 13% had a history of prior breast cancer, and of the gene disease-causing mutations found, over half had BRCA1 and 2 gene change, so that's where the main money was. In this series, so 10% had these CHEK2 and 6% these ATM gene changes, which we're really not quite sure what to make of. We're more aware of those genes being involved in moderate breast cancer risk. And then 10 or 15% had a combination of these other rarer gene changes that I mentioned, the BRIP, the RAD51C and D, and then about 10% the mismatch repair genes. So that's just to give you an idea if you had a big group of women with ovarian cancer, organising genetic testing, perhaps what you're likely to find. And so perhaps I'll leave it there and pass it back to Vanessa.
Great. Thank you very much, Marion, for providing us with all that valuable information. We have had quite a few questions come through. Unfortunately, we've only got time for a couple. So I will just get onto the first one. One of my daughters had borderline cancer at age 23 and again this year at 27. Do you recommend that my other two daughters get genetic testing?
So look, the borderline ovarian tumours, my understanding is they can be recurrent. So I think the fact of the recurrence doesn't make me think of like a separate primary. We do know some of these can occur in younger women. I would say generally what we do is take an assessment of the family history. So I'd be interested to know if there was any other family history of, like I said, bowel or uterine. So we wouldn't normally do BRCA1 or 2 gene testing, but we may consider testing for Lynch Syndrome. So I think if there's no family history of any cancer at all, we may not do it. On the other hand, the only thing I would think of is doing a screening test for Lynch Syndrome, but most likely that is a one-off and then sort of a recurrence of the original tumour pathology with that second episode at 27. So if she wanted, I think she could seek a referral to her FCC for them to explore the family history and just go through with that, but it may well be just a one-off if there is no family history.
Okay, great. Thank you. Next question is, I would like to know what treatment is available for the TP53 gene.
So we haven't mentioned P53 is another germline change that classically causes a condition called Leaf-Fraumeni syndrome or breast sarcoma. Rarely, ovarian cancer can be part of that. Unfortunately, there's no real. And the other thing I wanted to clarify is many cancers, whether they're lung or colorectal or ovary, would have a P53 gene change in the actual tumour tissue, but that's quite different to being like in the germline. So P53 is very commonly altered in many, many cancers. So generally those tumours are not treated any different, and we don't have any therapy to correct the P53 defect at a germline. So unfortunately, if someone does carry a P53 gene change, we just have surveillance regimens that focus on like breast MRI and whole body MRI. So there's no direct targeted gene therapy at present, but I suppose it remains a dream, particularly for people with germline P53 gene changes.
Okay, thank you. And we'll just ask one more thing. There are so many questions coming through. How does the location of the fault in the gene affect the risk?
If the gene change particularly occurs in certain parts of, say, BRCA1 or 2, we can know that that's particularly associated with a higher risk, say, of ovarian cancer, and that a gene change outside those ovarian cluster areas, the risk might be a bit lower. But overall, we wouldn't rely on that too much to alter what we do and what we say to a family. So while there are different risks, and for example, certain genetic alterations often say a large deletion where there's a large portion of, say, the BRCA1 or 2 deleted, we know that can correlate sometimes with really strong family history. So young age onset of breast cancer, very high chance of someone being affected, say, at a young age or having bilateral breast cancer. So a very strong family history. We do know, we take note of certain gene changes as being sometimes very risky, say for people that have it, and others that don't seem to be acting as strongly as we'd expect. So there is certainly a correlation, but generally we treat most people and give advice similarly, irrespective of where. If it's a disease-causing alteration in BRCA1, our advice is usually going to be the same. Look at breast risk, look at ovarian cancer risk.
Great. Okay, well, thank you very much, Marion. I know you stepped out of the clinic to present this, to do your presentation, so I will let you go. So thank you very much again. We really appreciate your time and all the information you've shared with us. So I'd now like to bring to the microphone our final speaker, Ms. Christine Christie. I'll hand it over to you, Christine.
Thank you, Vanessa. Hi, everyone, and welcome. As Vanessa said, my name is Christine, and I have been asked along today to share with you my experiences with genetic testing and its effect on our family. I think it's reasonable to say that I have come to an ovarian cancer diagnosis from a slightly different angle to many women, and I like to think that our family's story might be a cautionary tale for other people out there. I feel it shows the value in having the courage to undergo genetic testing if there is any suggestion that you or your family might be at risk of carrying a mutation. It would be very easy to just put it into the too hard basket. But I also think that it highlights the value in understanding the risks associated with your genetic status, and also the value in taking that knowledge, learning more about it, and then making considered choices that sit well with you. To understand why genetic testing has been important for our family, we have to look back over a number of generations at the history of cancer in my father's side of the family. I always knew growing up that Dad's mother had breast cancer, one of his sisters had ovarian cancer, and another of his sisters had breast cancer. My dad was just 13 when his mother died. His sister with ovarian cancer died when I was 8, and his sister with breast cancer died from the effects of treatment when I was in my mid-20s. As an adult, I also learned that my great-grandmother had died of breast cancer too. For some inexplicable reason, and I'll never understand why, I always felt that this family history of cancer was important to me. At times, I think the rest of the family thought I was a little bit preoccupied by it all. And although it was not a topic that was talked about frequently in our family, and it never interfered with my life in any way, it was always there in the back of my mind as something that I needed to be aware of. The women were very much missed in our family, and their deaths from the same disease was always the elephant in the room, so to speak. Everyone just managed to get on with their lives and hope that cancer did not appear again. In the early 1980s, I became a nurse, and that education meant that when the Brca genes were discovered in the mid-1990s, I sat up and took notice. By that stage, I was married with a couple of young children of my own. In 2001, aged 35, I discovered a small breast lump. My heart sank and the fears of cancer were real. Fortunately, though, after a biopsy, that lump proved to be benign. As a result of that breast lump, though, our family's cancer history came to the attention of my breast surgeon, and with his encouragement, I attended a Familial Cancer Centre to seek advice regarding the possibility of genetic testing based purely on our family history. Before attending the appointment, I had to fill in a family tree for both sides of my family that identified any cancers that family members had had, so that the counsellor could look at it and assess the potential for our family to carry a mutation. I had to ring up relatives, discuss histories, and a number of those relatives I hadn't spoken to for years. And I spoke at length with my parents to be sure that I was presenting information that was accurate. At the appointment, the genetic counsellor did identify our family as high risk for carrying a mutation, but she advised me that genetic testing was not possible, as at that time, testing could only be offered to a family member who actually had cancer. And as I said earlier, all family members had long since died. In 2001, the science of such genetic mutations was still too new. And as the counsellor told me, it would have been like looking for a needle in a haystack. I, along with other members of the family, was advised to undergo high-risk surveillance of my breasts. There was no specific recommendations for ovarian screening, however, beyond the suggestion that risk for ovarian cancer did not rise until mid-40s. Time slid by, along with yearly mammograms and breast ultrasounds and several, again, fortunately benign, breast biopsies. And then in late 2013, aged 47, I presented to the same genetic counselling service for some updated advice. Part of my motivation was my daughters. They were growing up and leaving home, and I did not know what to tell them regarding their risks. I wanted some insight so that I could advise them if there was anything that they needed to do. At the appointment, I was told that testing could now be done on our family, and that over the years since my first appointment, a database of known mutations had been built up, and that our genetic structure could be compared to that database to try and identify any abnormalities. I was told, though, that our family did not meet guidelines for funding, and we were going to have to pay 100% of the cost to have that testing done. The genetic counsellor also wanted to test my dad first, instead of me, as he was the blood relative closest to the women who had been affected by cancer, and there was a higher chance of finding something in him if something did actually exist. After waiting 3 months for an appointment for Dad, out came my credit card, and in early 2014, my dad was the first in our family to undergo genetic testing. At that time, they tested 4 of Dad's genes to look for a fault. I'm incredibly grateful to my dad for so readily agreeing to do that testing, as ultimately it has made an enormous difference to me and to our family. The results had to be received at a face-to-face appointment with a genetic counsellor, and so my dad asked me if I could get his results for him. Travelling to the city from their rural location was just too difficult. We waited 2 months for Dad's results to come back, and they showed that he had tested positive for a fault on his Brca1 gene. And that fault did put carriers at increased risk of breast and ovarian cancer. On the same day that I received his results, I underwent my own genetic testing. Now that a fault had been identified, any further genetic tests were fortunately covered by funding. When my results came back 2 months later, I learned that I had inherited that Brca1 fault from him. My husband was with me when we received the results, and I recall saying to him, well, that's not surprising. Though there was a 50% chance that I had not inherited the fault from Dad, testing positive just reinforced all that I had ever felt, that this was an important issue for me. While waiting over those months for the rather time-consuming process of testing to unfold, I had given a lot of thought to what I would do if my tests came back positive, how I would manage the risk, and how I would move forward with that knowledge. By the time I received my positive results, I was 48. So I immediately arranged an appointment with a specialist gynecologic oncologist to organise surgery to decrease my ovarian cancer risk. My ovaries and associated anatomy had served their purpose well, but I felt that they now represented an unacceptable risk to me. A mere 8 weeks after learning of my Brca status, I underwent a bilateral salpingo-oophorectomy and hysterectomy. 36 hours after the operation, just when I was expecting to be discharged from hospital, the surgeon came into my room, sat on my hospital bed and told me that a small tumour had been identified on pathology, that I had cancer, a high-grade serous epithelial ovarian tumour. That conversation is firmly embedded in my memory. I recall a weird sense of disbelief. There I was thinking I had been going to decrease my cancer risk when I actually already had a tumour. I still look back on that day with a strange sense of disconnect, like it was someone else's experience or a movie that I had been watching. As I'm sure many of you can relate to, things moved quickly from that point. Oncology consultations, the PET scan, meetings with oncology nurses, loads and loads of pamphlets to read, many tears, endless questions with no answers, overwhelming fears, and 6 rounds of carboplatin, paclitaxel chemotherapy. But here I am now, approaching 5 years since that surgery, and extremely grateful to be in good health. That genetic test was the one thing, the only thing that enabled me to be fortunate enough to get an early cancer diagnosis. A couple of weeks prior to getting my genetic results back, I had had ovarian screening done, a CA125 and a transvaginal ultrasound, and the results were perfectly normal. I was also completely well with no symptoms whatsoever to suggest that anything was wrong. Having that early diagnosis means that my chances of remaining cancer-free are higher than if the cancer had spread and I had become symptomatic. Of course, no cancer diagnosis is good, as I'm sure everyone can agree. I am grateful that I was curious enough to investigate the family history, and I am grateful that I had the courage to go ahead with genetic testing. And I am also grateful that on hearing of the risks of carrying that mutation, that I decided to act on it. While genetic testing ultimately did not prevent me from getting that cancer diagnosis, it has enabled other family members to undergo testing and become aware of their risks. Hopefully those who have tested positive will now be able to avoid a cancer diagnosis. Knowing about that pesky mutation has given us an opportunity to deal with it, to manage it, and to take some sort of control over our own health. Since completing treatment for the ovarian cancer, I have also undergone prophylactic bilateral mastectomy with reconstruction to decrease my high lifetime risk of breast cancer. Of course, the thought of undergoing genetic testing can be daunting. While the actual process of attending a familial cancer centre, undergoing the genetic counselling session and having the blood test were all really quite straightforward, I'll be the first to admit that I was extremely nervous waiting for my results to come back. I was aware that finding out this information that I had thought had ramifications for others in the family. I'll also be the first to admit that after I found out I did carry the Brca1 mutation, that I was uncertain, nervous and scared of the surgeries that I had decided I needed to do. Also, I wasn't sure how other members of my family would view my decisions. But I need not have been concerned. Everyone in my family has been very supportive and grateful, I suppose, to finally have some understanding of why so many members of our family had to go through a cancer diagnosis. Since discovering the mutation, all of my siblings, as well as my cousins on Dad's side of the family, both male and female, have undergone testing. 50% of us have inherited the fault and 50% have not. My 2 daughters, who are now both in their 20s, have also tested. One has inherited the fault from me and one has not. My 2 female cousins, who have inherited the fault, have undergone risk-reducing surgeries, and thankfully neither have had a cancer diagnosis. My daughter, who has the fault, is currently doing high-risk surveillance. She will make her own decisions with the full support of her family as she needs to. As a young woman, she has plenty to think about, but at least she is moving forward, knowing that she carries a risk, knowing that she needs to be vigilant, and knowing that she has taken some control over her own future, rather than simply waiting for the hands of fate to deal her cards. The only regret that I have throughout this journey is that I let time slip by and that I did not return to the Familial Cancer Centre for that second time earlier. Of course, regrets serve no good purpose whatsoever to anybody, so I do the only thing that I can do, and that is move forward with my life as best I can. I will say though, that the science of genetics is very much an evolving field, and I think it important that we continue to monitor its progress. What might not seem applicable today might well be applicable in the years ahead. We all need to advocate for ourselves and be as informed as we can be for our own health. Through family research, I have identified more distant branches of the family that might carry this mutation, and I now know that the family cancer history was more extensive than I was aware. I have identified 3 of my grandmother's cousins as having died of breast cancer and who quite probably carried the same mutation. I have managed to contact a couple of people in these family branches, and I was very nervous about making contact with them and telling them of the genetic fault. I was a complete stranger to them, and I felt like I was lobbing information into their lives that they might not want. Like tossing a hand grenade, once tossed, there was no taking it back. But I felt that I had a responsibility to bring this awareness to these people. Generally speaking, though, they have been receptive to the information that I have shared. They have been aware of cancer in their families, so it was not a total surprise for them. How they choose to proceed with the knowledge is their decision to make. At this point in time, I haven't been able to locate all branches of the family who might be affected, but I continue to try and find them, and I do this for a couple of reasons. The first is that I think of my aunts, my grandmother and my great-grandmother, as well as my grandmother's cousins. I ask myself what they would wish me to do, and every time I ask the question, I think that they would encourage me to make the most of an opportunity that they never had. Secondly, I would like to think that if one of the other branches of the family knew about this mutation, that they would have tried to contact our branch and let us know. There are 2 quite famous quotes that also keep me moving forward and encouraging others to consider looking at the option of genetic testing if they are concerned about a history of cancer in the family, or if they have a personal history of cancer that might indicate the presence of a mutation. One is a quote used by a number of influential people, including John F. Kennedy, and it says, "It is better to light the candle than curse the darkness." And I think that quote is rather apt. The light of knowledge has the potential to give families options instead of just stumbling along, not being aware of the risks that they carry. The other quote comes from Mary Claire King, who was instrumental in identifying the Brca genes and recognising their role in cancer development. She said that to identify a woman as a carrier of a genetic fault only after she develops cancer is a failure of cancer prevention. While I did not avoid a cancer diagnosis, there is no doubt that identifying the genetic fault changed the course of cancer for me. I would like to think that other members of our family now have the chance to avoid cancer, and that can only be a good thing. So, in conclusion, I'm sure you can see that I'm quite an advocate for genetic testing. My experiences have clearly shaped my attitude and approach. As a result, I'm keen to encourage anyone who might have such a genetic predisposition for cancers to try and find out, not only for themselves, but for the benefit of their families as well. I'll now hand back to Vanessa.
Thank you very much, Christine, for that, for sharing your journey. What an incredible insight. And you've really highlighted the importance of genetic testing and being proactive with your health. So thank you for being so honest and open. We do have a couple of questions for you. The first one is, what would you have done if your father had been reluctant to undergo genetic testing?
I was really lucky that Dad was very keen to step up and be tested, but I think if he had said that he wasn't willing to travel to the city and get it done, I would have just presented back to the Familial Cancer Centre, and I'm sure that they would have gone ahead and tested me without Dad having been done first.
Yeah. Okay. And the second question, why did you see a gynecological oncologist for your surgery instead of a normal gynecologist for preventative surgery?
Yeah, it's sort of recommended in the Brca setting or the genetic mutation setting that if you do have a presenting for prophylactic surgery, that one of the specialist surgeons does it, so that he's the best person to observe if there's likely to be an unidentified cancer discovered during the surgery. And he will also send the tissues off for in-depth pathology analysis to try and identify small tumours that he might not see during surgery. And that happened in my case.
Yeah, great. All right, well, thank you so much. We will leave it there because I understand we have gone over in time, so I do apologise. But thanks again, Christine. We really appreciate you giving up your time and, like I said, just sharing your experience and your journey and being so open and honest. Thank you very much.
You're welcome.
So once again, I'd just like to say a big thank you to our speakers, Megan Cotter, Associate Professor Marion Harris, and Christine Christie. We really appreciate the information that you've shared today and the time that you've given us. Thank you, everyone, for being on the webinar today. We really hope that you have found it valuable. Like I said at the beginning, the recording of this webinar will be posted on our website over the coming weeks, and you'll receive an email with a link to the recording in the next few days. In a moment, you will be directed to an evaluation form. We would really appreciate if you could take a moment to fill that form in, as it's extremely important to us and it will help us to plan our future webinars. If you have any other questions you'd like addressed, please don't hesitate to contact our information and support line on 1300 664 334. Thanks again, everyone, and we hope to see you for our next webinar later in the year. Enjoy your day. Goodbye.